come in with hemoptysis. And it's not easy to control bleeding in these patients. Of course, transamine helps. You may need massive acute bleeding, may need FFP, cryoprecipitate, or platelets. And in selective patients, you can also consider closure of these vessels as a potential therapeutic option in your cath lab. Anticoagulation is not routinely used in these patients because you can actually cause more bleeding, hemoptysis, stroke, hemorrhage. If you really want to give them something, most of the times we will only give them aspirin, and that too has to be stopped if they start bleeding or if they get an episode of hemoptysis. And of course, they need to be managed for biventricular dysfunction and severe pulmonary hypertension with pulmonary vasodilators. Lastly, what are the general measures which you need to do in these patients with Eisenmenger? Of course, fluid balance and climate control, oxygen supplementation. Often we send them home on home oxygen. I think one thing we know is that it improves their quality of life. But whether it leads to longevity or long-term outcome, I think the answer is we don't know. And remember, these patients also need infective endocarditis prophylaxis. Tetralogy. Many of us see tetralogy in adult age group. And if you look at the literature, majority of them would die by 5 years of age. We often send them home and say, come back at 5 years. 50% of them would die. So please don't send tetralogies home, send them to a pediatric cardiologist because they do not survive. The survival after 20 years is 12% and after 40 years is only 2%. So the percentage which you are seeing are already natural selection of children with tetralogy of fellows. They can present with either cyanosis or any of those complications which all of us know with brain abscess, endocarditis, hemoptysis, stroke, hematological abnormalities, infertility. Remember, as one of the presentations, I have certainly seen few patients where infertility was the presenting sign. They never knew that or they never told the family that the girl had a tetralogy or a congenital heart disease. So I think it's important to remember that again, tetralogy is not a simple lesion. You may have multiple VST. By the age of adult age group, you may have a small LV with EDV, diffusely small vasculature, disconnected pulmonary arteries, a very high hematocrit, coexisting cardiac lesions, particularly large MEPCAs, and of course, you should also see whether the patient had a previous surgery or not. PVR, if it's severe, up to 20 to 30% according to the current literature of these patients would need pulmonary valve replacement. And I think Brigadier Khurram is going to talk about percutaneous pulmonary valve replacement, so I wouldn't go into details, but replacement of pulmonary valve we know is indicated in many of these patients as they grow older. Coarctation, I think systemic hypertension, heart murmur, femorals may be palpable, but many of these actually present with complications of coarctation. And you remember, what is the natural history of coarctation? The ones which you are seeing as an adult cardiologist are the ones who are natural survivors. Majority of these patients would die in first year of life. So by the time they are 40 or 30 years of age, 80% of patients have already either died or have been operated. Again, management is, you can go for balloon or stent implantation. Surgery is rarely indicated, and most of us this day and age would either put in a covered or a bare metal stent in patients with coarctation of aorta, with very selective patients who would need surgery in these patients. There are a few general principles like physical activity, sports, mental health, neurodevelopmental issues. What about acquired heart disease, associated conditions, or non-cardiac surgery? I think my simple message is you do not need to stop these patients. Most of the times they stop themselves. So you do not need to restrict their physical activity unless they have an obstructive lesion. And that obstructive lesion is obviously either coarctation, aortic stenosis, or hypertrophic obstructive cardiomyopathy. Similarly, many of these patients have mental health issues. As they are growing older, you would find many of them coming to you and say, why can't we participate in physical activity? Why can't I do this? Why can't I go to gym? Why can't I be like other children who are in my class and so on. So they really need a very specialized care in that growing age, particularly between 16 and 25 years of age. Acquired cardiovascular disease. We as pediatric cardiologists are not experts in management of hypertension, coronary artery disease, dyslipidemias, diabetes mellitus. This has to be managed by an adult physician or an adult cardiologist. So I think that emphasizes the need for the development of this specialty. Associated diseases, as I mentioned, diabetes, obesity, dyslipidemia, and hepatitis. Non-cardiac surgery. Many of these would be referred to you as they want to have another surgery for hernia, appendicitis, any other condition which needs, and you need to advise that surgeon as what is the special thing about these patients with adult congenital heart disease. You need to be trained into that. So, last two slides, who should manage them? I think what is happening at the moment is that they are falling between the cracks, and it's a medical orphan. Particularly in this country, adults with congenital heart disease are orphans. There's nobody looking after them. It's only the pediatric cardiologist who by default is looking after them because these patients were seen by them as child, so they continue. 30% of my current practice is adults with congenital heart disease. And I'm sure that's true for most of the pediatric cardiologists who are sitting here. The reason obviously is that we do not have a specialty, and that transition from pediatric to adult age group really needs to be looked at and debated. And of course, to begin with, you will need joint clinics between pediatric and adult cardiologists, and then a structured plan to organize this specialty of adult congenital heart disease. You need pediatric cardiologist, adult cardiologist, obstetrician, psychologist, electrophysiologist, and of course, pulmonary hypertension experts. Because these are the fundamental problems these patients are going to have. And unless we involve each one of them, we will not be able to manage this patient. But then you need one focal person. And that focal person has to be a cardiologist, which is called adult congenital heart cardiologist. And I think the solution is, of course, awareness, joint care to begin with. Similar criteria may be applied for any management, but I think we need to have a fellowship. Currently, we do not have a fellowship of adult congenital heart disease in this country. So what I'm going to request to the college, and I've already spoken to the President, College of Physician Surgeons, Pakistan, we need to have a joint meeting of pediatric cardiology and adult cardiology faculties, come up with a comprehensive program of adult congenital heart disease, and train people from both tiers, both adult and pediatric cardiologists who are interested in looking after these patients with adult congenital heart disease should be managed, and we need to establish a department of adult congenital in every cardiac center in the country, be it say private sector or public sector. Every cardiac institute must have an adult congenital heart program, and I think this is a full-time specialty. Experts can come from both routes. Management does not involve interventions only. Many of us think that closing an ASD makes you an adult congenital cardiologist. Please don't think like that. That's not true. Closing an ASD is the simplest thing on earth if you really know how to do it. But it's really the whole context of that patient which needs to be managed by an expert. And high volume of surgery and interventions, so the competence is crucial. It's not something that you are doing it an odd procedure and you think you can do it. And I think the time has arrived to formalize the specialty and its training. And I take this forum, and I would like to really involve the Interventional Society in addition to Pediatric Cardiac Society and Pediatric Cardiology Society to come up with clear recommendations to the College of Physician Surgeons, Pakistan, and then we take it to the respective governments. I will be more than happy to talk to the Punjab government and make sure that every adult cardiac center has a program and positions assigned for children, for adults with congenital heart disease. Thank you very much. I think I will be happy to take any questions because it's a very important
Masood, an excellent talk. We have known you for so long, and I know you work so passionately with the pediatric cardiology. And especially this gray zone, which you have been talking about so concretely, how to deal with that, this is commendable. Because adult cardiologists generally, as you have told, see very few patients of adult congenital heart disease. So most of the patients go to you, and the transition is really lacking. So commendable, absolutely commendable. One thing which I just want to point out is the area of pulmonary hypertension, which you have talked about. The recent guidelines have provided us new ways and tools to measure the pulmonary vascular resistance by echocardiography, apart from right heart cath. I was just talking with Bashir Harif yesterday, and there hasn't been a single adult right heart cath reported in the last couple of years. I'm sure you people have been doing. So I think you should also combine with the cath registry and register the right heart caths. But pulmonary vascular resistance should be calculated routinely, and there are vague cutoffs by various societies of 2.3, where you should close the left-right shunts, whether by catheter or by surgery, and a 4.3 where you don't. In between, again, there is a gray zone where you treat them, and then, so I would like your comment on that.
Thank you very much. I think you had two questions. One is the transition from pediatric to adult. I think we are going to establish a transitional clinic at every pediatric setup, because that's from where the transition is going to occur for operated cases with congenital heart disease and few unoperated cases. So every pediatric cardiology setup which exists at the moment in the country needs to establish a transition center for these patients with adult congenital heart disease. And then, of course, will come the cardiology institutes where their adult congenital heart programs need to be established. In terms of your second question, I think Professor Najam has a talk on patients with left to right shunts, establishment of pulmonary hypertension, and how to go about that. So I would leave that topic for the time being so that we can have a discussion after his talk.
I think that's an excellent idea. Professor Masood Sadiq has been the pioneer in a number of fields, and I've known him for over 2 or 3 decades. I think this particular specialty is of paramount importance in the developing world, particularly Pakistan. And we see more and more cases of adult congenital heart disease, and many of us can do nothing about it. That is one area which is so important, and as highlighted by Professor Masood Sadiq, I think we must go in for this as soon as possible and save, or at least alleviate or palliate a number of lives. The second aspect, probably connected with this, is the growing number of patients we see with pulmonary hypertension, either because of congenital heart disease or even adults with pulmonary hypertension. And greater knowledge and greater expertise and diagnostic facilities are required to diagnose this particular entity so that we can move forward and produce good results. So I think, Professor Masood Sadiq, you've taken the right step, and I think we must all support you, both the adult cardiologists, the cardiac surgeons, the pediatric cardiac surgeons, the pediatric cardiologists, and even the general physicians should know about it, and physicians at large in the entire community. Thank you very much.
So thank you very much for your kind comments, Professor Noori. I think we will take everybody on board. I think we are getting delayed.
I have a comment.
But I'm extremely grateful to Professor Zubair Akram, actually, because this has been ignored in few meetings in the past, and I'm very happy that the adult cardiologists have realized it as an important entity which needs to be jointly managed, as we talk about now, by both pediatric and adult cardiologists. Thank you very much, sir, for your kind comments as well. Thank you.
I have a comment. I think we need to understand that adult cardiology is totally a different spectrum of disease, and congenital heart disease is total spectrum of disease. It's not the matter of age, adult 18 साल का हो गया तो adult cardiology में जाएगा. In all over the world, now this pediatric cardiology term has been changed, and it is called structural and congenital heart disease. From both sides, they can do adult congenital structure, have different trainings factors, but main training is in pediatric cardiology, and then adult cardiology who wants to do that have some extra training. But it is not the same spectrum as adult cardiology. Adult cardiology deals with the coronaries, and they learn only that much structural heart disease as we learn coronary artery disease.
I would like to second on this, Dr. Masood and the audience, that pediatric cardiologists do the pediatric echoes themselves. So they study the congenital heart disease themselves. So the understanding of the congenital heart disease as from pediatric cardiology perspective is different. Rather than an adult cardiologist getting trained into pediatrics, he has never done echocardiography, and he still relies on technicians who do echocardiography. And then an adult congenital person should give up his adult cardiology practice and then confine to only congenital heart disease. I mean, there are a lot of caveats and hindrances and obstacles, so we still have to settle as to who is the best person who would deliver this particular science.
Thank you, Professor Mehnaz and Najma, for highlighting that. I think once we have this combined meeting of the faculties of both pediatric and adult cardiology, I'm sure we will be able to, inshallah, sort this out. Thank you very much once again. Thank you.
Thank you very much, sir, for a very brief and nice talk. Our next talk is from Professor Mehnaz Atiq. She is Professor of Pediatric Cardiology at Liaquat National Hospital, Karachi. She will do presentation on pregnancy in unoperated congenital heart disease, case-based presentation.
Just a minute, Dr. Mehnaz. Professor Masood Sadiq, as you know, obviously this specialty was, not catered for in the last two Pakistan Live, obviously. I'm sorry for that, and obviously I made sure that it's back, and it's such an important specialty. And I assure you, as President of Pakistan Society of Interventional Cardiology, you are part of us, and we are just a call away. And just let me know what you need at this level of Pakistan Society of Interventional Cardiology. And as you know, I am there in the Faculty of Cardiology at College of Physicians and Surgeons as well. So whatever you need, now it's me, assuring you, inshallah ta'ala, to all the pediatric cardiologists sitting here, that obviously from now onward, inshallah ta'ala, you'll get full support. Thank you very much.
Thank you very much. I'd like to thank the organizers for giving me this talk, which is very close to my heart. We as cardiologists, pediatrics and adult, whosoever is delivering this, should be aware of how pregnancy is going to influence the heart disease and how the heart disease is going to influence the pregnancy. Sorry. So who are the females who will reach the reproductive age group when they are unoperated? Majority of them are the acyanotic heart diseases, the ESD, VSD, complete AVSD, some of them, aortic stenosis, pulmonary stenosis, coarctation, and like Dr. Masood said, Eisenmenger. But the cyanotic heart diseases usually die, and very few of them will reach the reproductive age group, which is one very common is tetralogy, Epstein's anomaly. And some of the univentricular hearts may also reach reproductive age group. So what is the role of cardiologists? This is a big list that shows the cardiologist has to be involved right from the preconception to the end, and also advise. But in this lecture, I'm just going to touch base on a few of these. Although this is a case-based presentation, I'll just give a brief outline as to what you should understand before you start interpreting the cases that I am going to present. What is the mortality risk of maternal mortality risk? General population 0.005, average. In a corrected TOF, it's less. In severe aortic stenosis, 1%. You should realize that in pulmonary hypertension, a pregnant woman can die very easily. It's 30 to 50 in a developed country. So what is the risk stratification according to the lesion of the mother? Low risk, yes, we all know ASD, VSD, small disease is unoperated, is a low risk. But the intermediate risks are the ones who have large shunts, moderate aortic stenosis or pulmonary stenosis. And the higher risk will be the ones who have got systemic single ventricle, RVs as a ventricle, unrepaired or partially corrected or palliated cyanotic heart diseases, Marfan syndrome, and asymptomatic aortic stenosis with a peak gradient of more than 50 millimeters of mercury, and a very, very high risk in which pregnancy is best avoided or contraindicated. This is very important that the severe aortic stenosis, the pulmonary hypertension, LV dysfunction with an ejection fraction of less than 30%, poor functional class, Marfan syndrome, unrepaired, severe coarctation. So what you do is, wherever possible, you repair first and then advise pregnancy. So the maternal concerns are the hemodynamic changes that occur throughout pregnancy, labor, and postpartum period. They start in the first 5 to 8 weeks and peak in the late second trimester. And this is the time when the cardiac decompensation occurs. How does that happen? There's an increase in preload, there is a decrease in afterload, there is an increase in heart rate, and an increase in stroke volume in the first 2 trimesters and the third trimester due to the gravid uterus compressing the inferior vena cava. There is a decline in the cardiac output or stroke volume. This is during pregnancy, and during labor, which is even more challenging. Every uterine contraction releases 300 to 500 ml of blood in the maternal circulation, so overload. Pain will increase blood pressure, bleeding will decrease blood pressure. So there are a lot of changes that happen in pregnancy which a cardiologist should be aware. And what happens after delivery? If it was a normal delivery, everything returns to baseline in 2 to 4 weeks. But if it was a section, then it takes a little longer, 4 to 6 weeks. So what are the decompensation that can happen in a pregnant woman with congenital heart disease? Heart failure, right to left shunt or ventricular dysfunction, arrhythmias, which is very common, brady and tachy, low cardiac output due to obstructive lesions like aortic or pulmonary stenosis. Cyanosis, very important, pulmonary hypertension addressed. Poor functional class to start off with is a very bad thing. And sometimes pregnancy-related concerns are also there. So talking of heart failure first, 2 peaks occur. One peak towards the end of the second trimester, which you should be prepared. And the second peak is peripartum and early postpartum. So actually, towards the end of the pregnancy, it is very difficult to differentiate between cardiac failure and the normal symptoms of advanced pregnancy. So at that point, it is best to admit and evaluate a patient. And if you think this is a cardiac failure, treat with diuretics. Give a good thromboembolic prophylaxis if you're putting to bed rest, because remember, pregnancy is procoagulating. Okay, you have a tendency to coagulate during pregnancy. ACE inhibitors, ARBs, aldosterone antagonists should not be used. Beta blockers can be used, and if refractory, digoxin may be used. So in nutshell, if you have heart failure with normal blood pressure, use vasodilators. If you have heart failure with low blood pressure, use IV inotropes. If you have refractory heart failure, then you should plan a premature delivery. Now this is to save the mother. And after delivery, you can use ACE inhibitors because it is safe to breastfeed with ACE inhibitors. The second most important complication, in fact, the most important complication is arrhythmias, which is atrial arrhythmias. And arrhythmia is very poorly tolerated by the fetus. So this is fetopathy or embryopathy is very common if you have got uncontrolled arrhythmias. Arrhythmias for the mother will increase the risk of heart failure and thromboembolic complications. They're commonly seen with tetralogy and other complex heart diseases, Epstein anomaly. So you have to carefully evaluate the arrhythmia and choose an appropriate drug. You can't use every antiarrhythmic drug in pregnancy, for example, amidron and all. So beta blockers will probably be your mainstay of treatment. But if the woman is severely symptomatic, it's better to admit and manage an arrhythmia. Cyanosis. We all know cyanosis is a risk factor for the mother as well as the fetus. So this is one chart that tells you that if you have cyanosis, where arterial saturations are less than 85%, then only 12% will be born alive. 88% of the fetuses will die. If your saturation is a little more better, 85 to 90, बहुत ज़्यादा फर्क नहीं है, but the survival of the fetus is much better, 45%. And if your saturations are over 90, there's a 92% chance of survival of the fetus. carrying to pregnancy. 50%, however, may have prematurity. So, does supplemental oxygen benefit the mother during pregnancy or help the fetus? There is no evidence, so this is not recommended. Erythrocytosis, it was just touch base. Phlebotomy is not indicated in women except when the hematocrit is very high or you have symptoms of hyperviscosity. And anticoagulation, some clinicians recommend heparin because of one of the causes of maternal mortality is thromboembolic phenomena. But that approach also has a risk of hemorrhage, hypovolemia, and death. So this is a double-edged sword. You have to carefully evaluate whether or not you would use one of the other modalities. Pulmonary hypertension has been talked. It's only 15% pregnancies go to term. Fetal deaths are very common. In Eisenmenger, even with mild cyanosis, they become very severe during pregnancy. It can be a fatal hypoxemia. Baseline may be mild, but during pregnancy it can become fatal due to fall in SVR and increase in right to left shunt. With breakdown during labor, again, the resistance increases. You can have fatal syncope in mother. So such women especially are also most susceptible to pregnancy complications like preeclampsia and postpartum hemorrhage. And majority of the deaths therefore occur in the first week postpartum. Pregnancy guzar gayi hai, aaram se, don't relax, because the worst is yet to come. Because majority of the mortality is in peripartum period and postpartum period. 50% of maternal mortality is in secondary, 33% in primary. Other than what we normally think is secondary hypertension live longer, but in pregnancy this is a very bad prognosis. So best pregnancy is contraindicated in pulmonary hypertension, please. So now the fetus, what is the risk factor for fetus? If the mother's functional class is poor, cyanosis, obstructive lesions, smoking, multiple gestations, and all that. So congenital heart disease occurs in 20 to 25% of babies of these parents, of this mother. So fetal echo is mandatory to do. When would you do it? In the maybe 18 weeks, maybe 20 weeks early. So if the baby also has complex heart disease, you offer the option of terminating a pregnancy. So the care of the mother is multidisciplinary. At least 11 disciplines should come together to take care of a mother who has unoperated congenital heart disease. So vaginal delivery is always preferred. But there's few conditions in which you may go for C-sections. Women with ascending aorta diameter, which is more than 45 millimeters, preterm labor, when you're on anticoagulant, severe aortic stenosis, you should treat them first. Heart failure, because anesthesia has bad effects on the baby and the mother. Endocarditis prophylaxis should be given in certain conditions, not routinely with low risk, but any form of instrumental vaginal delivery or C-section and unrepaired cyanotic heart diseases, all of them should receive endocarditis prophylaxis. So the case that I'm going to discuss is of a 26-year-old lady who had 2 first trimester abortions due to severe hypertension. Later on, investigation showed that she had coarctation of aorta. So what would you advise? You would advise treatment first. So this woman had a stent placed, and then after this, she had 3 children who were normal. Case 2 is a 20-year-old girl, unrepaired tetralogy of Fallus, saturation is 85%, hematocrit 55. So what are the risk factors? What are the fetal risks? What are the maternal risks? And what would be the special considerations in this? The risk factors are, this is uncorrected cyanotic. At 20, she may have some element of right ventricular failure, or she may be prone to arrhythmias. The fetal risks are the higher risk of fetal loss because the saturations are 85%. The high risk for congenital heart disease in the fetus. In the maternal risk, you have arrhythmia, right heart failure, low cardiac output, and as I said, thromboembolic phenomena can happen during pregnancy, during labor, and after and postpartum also. So the special considerations would be, you go for C-section or instrumentation if a 20 minutes or 30 minutes labor is not successful. You try to maintain oxygen about 80, hemoglobin about 16, and avoid cardiac overload, and heparin may be considered later during labor. Case 3 is a 21-year-old lady, diagnosed to have large PDA with severe pulmonary hypertension. She was advised against pregnancy, but now she is 12 weeks pregnant. So what happens? So this is her echo, which shows that she has severe pulmonary hypertension, tricuspid regurgitation, pulmonary regurgitation, dilated RA-RV. Functionally, RV is good, but still, she has a high risk. So what would you advise? Therapeutic termination, because she's only 12 weeks pregnant. And we know the Western mortality is 30 to 50%. With us, it's going to be even higher. Suppose she doesn't want to go for termination, then what would you give her? ACE inhibitors are contraindicated. You can give pulmonary vasodilator therapy. Supplemental oxygen may be given. Fetus, you should do a fetal echo like you would or do. IUGR is a very common problem with the fetus. But the mother needs to have her ventricular function and her right ventricular function and pressures all assessed periodically by echoes. If she develops arrhythmias or heart failure, treat accordingly. Endocarditis prophylaxis is required. And postnatally, ICU care for at least 1 week for pulmonary hypertensive crisis, thromboembolic events, because that is when she is going to die. Okay? She may tolerate the pregnancy, but after delivery, she may die. So this is a very important, because I have lost patients in the first week after delivery. Case 4, 24-year-old palliated for complex cyanotic congenital heart disease with single ventricle and pulmonary stenosis with bidirectional Glenn at 8 years of age. She was found unsuitable for completion of Fontan operation. She has atrial arrhythmias, so she is taking beta blockers for that, and saturations are 80%. She desires to conceive. So again, this is the single ventricle. She had a Glenn done, but she couldn't go through a Fontan, so she is cynosed. 80%. Risk factors. Incomplete palliation, single ventricle is a risk factor, cyanosis is a risk factor, arrhythmia she already has is a risk factor. Fetal risks are spontaneous abortion. These women don't carry on pregnancies very long. And even if they do, it's a premature birth, IUGR. And then the fetus is also at risk of congenital heart disease. And the maternal risks are, of course, she's going to cardiac failure, low cardiac output. There may be edema, ascites, arrhythmia, thromboembolic events, and endocarditis is also a threat. So the special considerations would be to give her aspirin and enoxaparin as and when required. There is this anticoagulation protocol for pregnancy, and maintain sufficient filling pressures and avoid dehydration. So can you do intervention during pregnancy? This was a very common question always asked. Yes, careful interdisciplinary assessment of the mother, weighing risk and benefit. Keep the radiation dose low, fetus, because the fetus is vulnerable. Intervention should be performed in the second trimester after completion of organogenesis, but before the uterus has become very large to prevent an intervention. Open heart surgery has also been done, but it carries a very high risk of fetal loss. So in summary, pregnancy in patients with congenital heart disease may be compatible with a successful outcome depending on the lesion. A multidisciplinary care is often required for optimal management, and that starts from the preconception, goes through the gestation, peripartum, postpartum, and also contraception. So this is not an easy one-time care, it's a very long-term care. And patients and their partners should be actively counseled and involved in all management decisions because of the high risks involved. And however, I just want you to understand one more thing, that many times the cardiovascular status of a woman worsens after pregnancy and delivery. So whatever she had a basic level, she may actually deteriorate. Thank you very much for your attention. Any questions?
Excellent talk. A very quick query. One of the things you mentioned was the risk of worse pregnancy outcome in terms of primary versus secondary pulmonary hypertension.
Yes, this is... Can I explain why?
I thought it was the other way around.
Yes, I mentioned that. In a normal population, it's the other way around. Okay? In pregnancy, there's a vasodilatation of the systemic circulation. If you do not have a shunt, the cyanosis will not worsen. The right to left shunt will not worsen. So they have a slightly higher risk as compared to a person who does not have a right to left shunt.
Thank you.
There is a comment on that. I think this group of patients who get pregnant with congenital heart disease, whether repaired or non-repaired, that are the worst patient who suffers from at the gynecological floor. They will straight away say, you will die during delivery, so go back to your cardiologist. Get this one, get this one. I think we need a more elaborative collaboration with the gynecological people, and whenever we have a such presentation, gynecologists should be invited to attend the session so that their fear can be out and the life of the patient can be made a bit easy.
The gynecologist is not a cardiologist. And those who are not cardiologists are always afraid of a cardiac lesion, be it small, albeit small. So you have to actually play the role, maybe even guide the gynecologists, okay? So you are probably the central person.
I actually advise a patient, if we have corrected the lesion, like we have closed the PDA or ASD or...
that is different.
I advise them never ever tell your gynecologist you have a cardiac issue.
No, that is wrong.
Otherwise, that will make your
it's better
life
be
miserable.
informed than get a surprise.
PDA बंद कर दिया, ASD बंद कर दिया, VSD, that is done for life. No, they should have some follow-up after 5 years or something and advise them to come before marriage or conceiving before conception.
But follow-up is a bit different. But the feedback that will get at the gynecological floor, that will be the worst thing.
Yeah, gynae people are very scared.
They will keep you coming to you. I have seen the patient with PFO, go back to your cardiologist.
Yes.
Go back to your cardiologist.
Asif, you
But
can't
it's
blame
okay,
them.
but
You
can
can't
write
blame them.
You can write a letter to them. Okay, now there is no problem.
Yeah, you can't blame them if they are scared. It's better to be scared than bold, I think.
Actually, in other countries, there is a multidisciplinary team who take care of the pregnant ladies, and there is a pediatric cardiologist there. So usually they have a common meeting with the gynecologist there and a specialist of adult congenital heart disease, and they plan together the meeting of such patients in which both are there. So I think if we can plan such things in our setups, I think that would be more useful.
Sorry, continue. I thought you have completed.
Okay.
No, I don't know. In Sindh, we have so many sessions like Go Right for Women. There are combined sessions with gynecologists, adult cardiologists, structural congenital heart disease. We have so many sessions with them. Like every 2-3 months, there is some conference like this. I don't know whether they are doing it here or not.
No, actually, I mean that we in clinics, we should have a combined clinics in which there is a gynecologist setting and then the...
See, this has to be a multidisciplinary clinic. You have to decide who are going to be involved in this care. You can't blame the gynecologist, I think, and because they are happy and comfortable with routine cases. This is a challenge for them.
I just have a very small comment. I think they are only a phone call away. That's what I do normally. If I see a patient who is pregnant, I just give a call to the obstetrician who is actually looking after that girl, and that resolves most of the things. I think they're only a phone call away. Please make sure that you call them and let them know what exactly the diagnosis is and how to manage those patients. Thank you.
Thank you very much.
Thank you very much, madam. It was very brief talk on pregnant women. Our next talk is a case-based presentation by Professor Brigadier Khurram. He is head of pediatric cardiology in AFIC. He will talk on pulmonary marrow replacement. Sir.
How to इसको आगे कैसे करेंगे? So before I go on to case presentation, I'll be talking about something basic about valves in general. Many congenital heart diseases require right ventricular outflow tract reconstructions. Almost 20% of newborns with congenital heart disease require having complex anomalies require surgical reconstructions using either a patch or a bioprosthetic valve or a valved conduit. So these lesions include tetralogy of Fallot, pulmonary atresias with or without VSTs, truncuses, transpositions, some form of double outlet right ventricles, and congenital aortic valvular anomalies previously treated with Ross procedures. Degenerated bioprosthetic valves and conduits with progressive RVOT obstructions with possible pulmonary stenosis and regurgitation. So severe PR may be present in almost 40 to 80% of patients 5 to 10 years after correction. Transcatheter pulmonary valve replacement therapy is a non-surgical option to restore pulmonary valvular function in children and adults with congenital heart disease. This procedure was first performed in a 12-year-old boy in 2000 with a successful outcome by Philip Bonhoeffer. As you can see, the guidelines for a pulmonary valve replacement are that the patient should be symptomatic with moderate or severe PR, or asymptomatic, then moderate and severe PR with RV dilation, or if the patient is asymptomatic with moderate to severe PR with ventricular arrhythmia, so class 1A, class 2 alpha, and class 2B indication. Just have a look at this algorithm. We see that the class 1 indication is a patient who has severe PR, moderate to severe PR with, is the class 1 indication. But what if the patient has moderate to severe PR and does not have symptoms? Then any two of the following, which include mild or moderate RV or LV dysfunction, severe RV dilation, right ventricular systolic pressures due to RV obstruction more than 2/3 the systemic pressure, progressive reduction in exercise tolerance. This goes in favor of class 2 alpha. And if you have still do not have any of these, then sustained ventricular tachyarrhythmias form the class 2B indication. Now, transcatheter pulmonary valve replacement is one of the most exciting recent developments in the treatment of congenital heart disease. We had the opportunity to place 2 pulmonary valves, the venous P valves in Pakistan, and this was the team where in 2019 where Professor Shakil visited us and Dr. Vorokon from Thailand. Now, in order to do a percutaneous pulmonary valve, you need to do the same basic tests, which include an ECG. You should do a good echocardiographic evaluation, which includes the quantifying qualitatively the degree of PR, PS if present, the right ventricular sizes and pressures and measurements taken, and functions of the ventricles and associated findings. The exercising test is actually advised. We have done none, but these include tidal volumes and minute ventilations and pulse oximetry, ventilatory anaerobic thresholds. MRI holds a very important position in patients we are dealing for valvular replacements, in which we can get an objective evidence which include end diastolic and end systolic volumes, derived indices, and stroke volumes, ejection fractions. CT will be helpful if you have an anatomy which goes more in favor of an obstructive lesion, so we can get measurements. In CT, we can also see the patency of the coronary vessels and whether there's going to be any coronary compression. 3D is a new modality where we can actually make a 3D model, and then from the image reconstruction, we do a patient-specific digital target analysis of the structures. Now, some of the patients may be considered ineligible for a valvular implant, and these include unsuitable RVOTs, those patients who are likely to develop coronary compression, those whose conduits are not as bad as we thought before, presence of branch pulmonary artery stenosis, or conduit stenosis that can be relieved otherwise. In this, it's actually a 3D reconstruction from MRI. You can see the pyramidal type of RVOT is actually a no-go for the deployment of a venous P valve. Then, like with any other interventions, you can have complications. Now, the valves which are already in the market are the Melody valves. They are available in 2 sizes. And this valve is actually made from bovine jugular. And it is primarily meant to treat RVOT conduits and bioprosthetic valvular dysfunctions. It has its own delivery systems, 3 sizes, and that's how it is. And then we have the sapien valves, both for native and non-native pathologies. This is a Medtronic harmony valve, which is like more or less like a venous P valve designed for native RVOTs. It's available in 2 sizes. Then we have the venous P valve. Our talk is going to revolve around this valve. It's a self-expanding porcine pericardial venous P valve. It is available in 2 designs, and it is developed by Venus Medtech Hongshu, People's Republic of China. My patient in which we had the opportunity of doing 2 cases. So one of the patient was 18 years old. He had his primary repair done. I stand corrected, as Sir Masood has said, it's not corrective surgery. It's a primary repair done for tetralogy of fellows when he was 1 year, 5 months old. He was in NYHA class 2. This is an MRI which was actually done in Lahore, and as you see that his indexed and diastolic volume was 157, and his indexed systolic volume was 59. He had a regurgitant fraction of 29%, and he had mild tricuspid regurgitation, no RV outflow tract obstructions, no aneurysm formation. These are the various sizes of the pulmonary arteries that were done. This is his procedural ECG. Now, we did this procedure under general anesthesia. So what we did was that the right and the left groins were used for cardiac catheter study. Arterial venous lines were taken in the left groin using a 6 French femoral short sheath. And another venous line was taken on the right groin using a 6 French femoral short sheath. So we actually had 3 lines in place. Check angiograms were done to assess the morphology of the femoral veins. We gave the patient heparin, 100 units, international units, in order to keep his ICT level more than 250 seconds. Using a 6 French pigtail, RV angiogram in RAO30 cranial 15 was injected at 20 mils at a rate of 20 per 20. The frame rate was, so this is an RV angiogram being done in RAO30 cranial 15. Similar injections in the same plane were given with 6 French pigtail placed in the main pulmonary artery, and another injection in LAO30 cranial 15. Angiogram in LAO90 was repeated with pigtail at the same place. The morphology of the pulmonary artery, degree of regurgitation, and pressures were noted. Pressure gradient across RVOT was calculated. Then we used a Lunderquist wire, 035, and it was parked deep in the LPA using a 6 French MPA. Using the left groin, we used the pigtail to first take down the EDP and then pulled it up and placed it in the aortic root. And using the same left groin, we used another 6 French pigtail and placed it in the right ventricle to take continuous angiograms. A 34 millimeter ASD sizing balloon was used in order to measure the annulus, pulmonary annulus. The balloon was inflated using a contrast dilution of 1:5, and then a simultaneous injection was given in first in the arterial root, and then in the RV angiogram was taken. So enough contrast was injected in so that it completely occluded the right. As you can see, the right ventricular outflow tract is completely occluded. So no flow is going into the main pulmonary artery. The procedure was then repeated with the camera in RAO30 cranial 15. And this time we did 2 injections. One, we placed the catheter in the right ventricular angiogram and see no antegrade flow. And another was done in the aortic root in order to see the patency of the coronary vessels and also see whether it is being compressed by the dilated balloon. Now, before I dwell further, I would like to show you how this engineering of this valve is. It has a main shaft and it has two flared ends, the venous P valve. It has an outflow and an inflow. The flare diameter is 10 millimeters more than the diameter of the shaft. Length of the shaft is in 3 sizes, which are 25, 30, and 35. How do we do it? We measure the waist. We measure the most dilated parts and the lengths. As you can see, as you can see here that we are taking down the lengths in different angles. So first of all, once that is done, we decide the landing zone. We take measurements at all these points. We decide the landing zone. And then this is what the flare ends would look like once the device is deployed. So after we have decided the landing zone, we can take down the length. The length is, if the length is something like 22, so we will choose a size of a device which is 25 millimeters long. And then what we do is we decide the diameter. So you can see that the diameter of the device should not be larger than the maximum diameter. In this slide, you can see the max is 30, so our device should not be more than 30. And should not be larger than the waist, so waist plus 6 millimeters. So waist plus 6 millimeters means 26 to 28 millimeters. The device, so we will choose a device, 26 millimeters and 25 millimeters. The diameter is 26 and the length is 25 millimeters. So this is how we calculate. We selected venous P-valve. In our case, we selected a length of 25 with a diameter of 34 using a 24 Mullen sheath. We pre-dilated the groin, and then we took numerous injections in various planes. As you can see, now a Mullen sheath is being passed forwards over the Lundercoast wire, and simultaneously check angiograms are being taken. We also did the same thing in through 90. And this Mullen sheath is advanced that it comes and stops at the anterior border of the trachea. A 6 French pigtail was placed in the main pulmonary artery for later injections. The valve was then slowly advanced and steadily unsheathed. As you can see, the valve is being advanced and is being unsheathed. Oh, God. Repeat check angiograms were taken during the positioning of the valve in LO 90 and 30. And the carot of the valve was advanced distal to the trachea. I'm sorry for this, it should have been lower. See, the carot of the stick is actually slightly posterior on the posterior wall of the trachea, and we are bringing down the Mullen sheath. The flare end of the valves was adjusted in the main pulmonary, some say main pulmonary artery, and some in literature in the proximal LVA. Repeat check angiograms were taken, and slowly and gradually, with the help of that device that we had at our end, a clockwise rotation, so that we could deploy this sheath in such a way that the proximal marker coincided with the proximal waist. The remaining constrained valve was progressively exposed under guidance from repeated RV angiograms. Now, as you can see that we are opening up the valve slowly and gradually after we have taken down the sheath. The valve is, we open up the valve by rotating the device which is at the end, making sure that these markers, the lower marker is at the decided waist. Slowly uncover, frequent check angiograms, match distal and proximal markers with references. And this is how we are trying to remove it. And this is the device which is at the operator's end. Slowly and gradually, the device is being deployed. And once we have deployed it, this is how it looks like, the pigtail in the RV, with the pigtail in the RV angiogram. The carrot is the problem. The carrot is slowly withdrawn by pushing the wire forwards and making sure it does not get itself tangled within the framework of the device by pushing and pulling the wire. So now once we have done this, we do check angiograms both in the main pulmonary artery and the RV angiogram. A perfusion of both lungs is checked. We see we have not jailed any of the branch PS. We look for paravalvular leaks. We also look for apposition of the valve at the RVOTMP area. A last angiogram check for pulmonary regurgitation, pressure gradients are taken down. This is the echo following the procedure, which shows laminar flow. We removed the sheath, figure of 8, can use per close proglide. Heparin is given for 48 hours. You may need to have an ultrasound done for retroperitoneal hemorrhages. Patient is placed on double antiplatelet for an indefinite period prophylaxis antibiotics for all major dental and urogenital surgical procedures. And this is my patient. He's a handsome young boy. And all credit goes to the team there. Some of the references, and I thank you.
Short of time. We are short of time. Questions will be taken at the end.
Okay.
Thank you. Thank you very much. Our next talk is from Professor Najam Haider. He is Professor of Pediatric Cardiology at RIC. He will talk on assessment of operability in left-right shunts with pulmonary hypertension, to close or not to close. Professor Najam.
इसको चलाएं हाँ Bismillahirrahmanirrahim. Today I am giving to talk about the assessment of assess the operability of in left to right shunt with pulmonary hypertension, to close or not to close. It is well established now that patients with large left to right shunt lesions may be cured if operated early in the life. The decisions of repair and defect is not simply based on the numerical values of the PVR. Several recommendations are available to guide decisions making for operability in patients with left to right shunt lesions, and most of these recommendations favor conservative strategies and consider operating patients with PVR index lesser than 4 to 6 wood unit meter as safe. In country like Pakistan, low socioeconomic country, large number of patients with shunt lesion present with raised PVR at an older age. Decision to repair the defect in such patients is debatable, since the clinical course of such patients it adversely affect if they are operated at that time. Similarly, lack of well-defined clinical cutoff to identify this point or zone of irreversibility further complicate the decisions making, especially for the cardiologist. Thus, identifying that patients who has modifiable or reversible elevations of PVR remain a major challenge for cardiology. Now, the main thing is, why worry about the pulmonary hypertension in CHDs? Especially in the developing country, most of the world has limited access facilities, surgical facilities to treat such adult CHDs. And some CHD present late anymore and they remain asymptomatic at the childhood group like ASDs, and some cases detected late in the life like VSDs, PDAs, because of not proper referral in our part. And the source of development and progressions of pulmonary hypertension, it varies with the lesions in CHDs. Therefore, first of all, we have to look the basic concept. Then how do we decide on operability of left to right shunts today? What are the indications to perform catheterizations? And what are the limitations of the tool that we have in a country like Pakistan? If you look at the basic concepts, there is a pre-tricuspid shunts and the post-tricuspid shunts. In case of pre-tricuspid shunt, there is gradual increase in QP as RV accommodates and enlarge slowly, like a case of ASD, PAPVC, Gerbody syndromes, and coronary artery fistula to the right atria. while in case of post-tricuspid shunt, there is a direct transmission of the pressure head like VSD, PDA, AP windows, and the coronary artery fistula to RV. Therefore, in such cases, having left to right shunts, what happened with increased flow, the permeable blood flow will increase, that gradually cause the endothelial dysfunctions and vascular remodeling that leaded to increase in permeable vascular resistance, and at the end, there is the reversal of the shunt. If you look at, there are many factors that influences development of the permeavascular diseases. This is not only the anatomy of the defect. If you look at the anatomy, this is one part that include pre and post tricuspid lesions, whether it is a single or multiple, and having an associated lesion like VSD with PDA, VSD with AP windows, and similarly the permevenous hypertensions that also increase in the factors that also included in the development of the permeavascular diseases. Other than the anatomical defect, we have associated conditions like lungs and airway, hypoxemia, high altitudes, and the syndromes. Similarly, certain unknown influences that also lead increase in the permeavascular resistance is the genetics. Genetic factors is also well documented. And finally, the time. Time also decide the development of the permeavascular diseases, natural survivor, late diagnosis, and the silent disease. If you look at the defect versus time, some CHDs are very prone to develop CHDs earlier in the life, like infancy, case like TGA, VSD, PDA, even truncus till the age of childhood. And some cases develop later permehypertensions in the adolescent like restricted PDA, ASD, VSD, and the early adult patients can develop with PFO and sinus venosus ASD. They are prone to develop permehypertension. Now, if we look at the operability in left to right shunt, how we decide on operability of left to right shunt today? What tools we have and what are the limitations? As one of my senior colleagues told that right catheterizations is now going to be obsolete, and most of the center, they are not doing the right cath. He's absolutely right, because there are many tools in which we can decide about whether we have to do the cath or not. For deciding what tools we have, the important things for my fellows and for my juniors, clinical evaluation is one of the more important factors. What we have, we can easily do the X-ray, ECG, oxygen measurements, and echocardiography. Echocardiography, in the most of the case, you can decide about the operability or not, and development after MRI. If you have a good operators and the center where MRI can tell you about the disease and the vascular thing. And finally, we will go to the catheterizations. What principles govern decisions on the operability? In case of tricuspid shunts, permehypertension, anything more than mild warrant concern, especially if the basal shunt is not obvious. This is a basic concept for decisions about the operability. And in post-tricuspid shunt, generally operable if there is evidence of significant shunt at the basal state, irrespective of the permeable artery pressure. Therefore, your echo and clinical findings and ECG X-ray can give you a better decisions on or guideline for decisions about the operability of that patient in left to right shunt. Therefore, certain principles we have to observe and we have to follow. What age is an important variable, and benefit of doubt must be given to the younger patients. If you have a patient of 1 year old with a large VSD, with a bidirectional sending, it should be closed, because a benefit should be given, rather than doing the cath in such cases. Similarly, as we see that most patients have lungs, airway, or ventilation issue. It can also elevate your PVR and confound the assessment. Similarly, permevenous hypertension can result in reversible elevations in the PVR. Therefore, these are the major simple principles that we have to look. Therefore, non-invasive evidence in large left to right shunts. What are the main things that we can see? Marker. Yes. The failure to thrive in the younger patients, or if you look at the saturations, room air saturations more than 95, and in the X-ray you have a cardiomegaly along with plethoric lung fields. On an ECG, there is a left axis with the Q in the lateral lead on ECG, reflect you the good LV forces. And if you look at the echo, predominant left atria and left ventricle along with the flow and direction of the shunt. These are the cases in which it is evidence to show that the patient is operable in these conditions. And what are the clinical conditions which are inoperable? You can see marked cyanosis and clubbing and loud P2 along with systolic or diastolic murmur of tricuspid regurgitations and the pulmonary regurgitations. If room air saturation is less than 95% and you have a normal heart size in X-ray along with oligemic lung field, and on ECG there is right axis and no Q in lateral lead that dominates, that indicate the RV forces. And if you look at the echocardiogram, there is dominance of right atria and right ventricle and the reversal of shunt. So that indicates inoperable conditions. Then in which conditions we have to decide about the cath? This is very important question. If you look at that, is a clear evidence of left to right shunts, typically younger patients, age is also included, no need for cardiac cath. Similarly, if there is a reversal of shunt and older patient, no need for cath. So where we need for cath? Cath is basically required on the borderline cases in which you have a raised PVR and operability is uncertain. These patients need cardiac cath. Therefore, if you look at the numericals value, if this PVR is less than 5 to 7 and decline in PVR after giving vasodilator, that condition indicate that this patient is operable. Otherwise, if the PVR is more than 5 to 7 or more than 8 Wood unit and there is no decline in PVR after vasodilator, that give you indication that this patient is non-operable. If you look at the numericals, I'm not going in detail, PVR, how to calculate the mean permeable artery pressures and the permevenous pressure along with the blood flow, oxygen consumption, and permevenous oxygens and permeable artery oxygen saturations. But if we look at the baseline, we can also decide that if the PVR index is less than 6, ideally less than 4, then it is favorable. If the PVR and SVR ratio is less than 0.3, that is favorable. If it is more than an 8 Wood unit and more than 5%, the ratio is more than 0.5, then that is unfavorable for the patient to operate such cases. And after giving a vasodilator, if there is 20% fall in PVR, that indicate that this give the favor of the patients, you can do the surgical repair. But there is still limitations in the cardiac catheterization data. There is lack of direct measurement tools like oxygen consumption, assumed permevenous saturations, these give you the calculations error, non-physiological state, environmental factor. What are these factors? Improper taking sample for the blood gases, oxygen saturations, or delay to reading for these saturations, or improper calibrations can give you the false reading. Therefore, calculated PVR has not been adequately standardized against the gold standard for surgical outcome. What else we can do other than cardiac cath in the cath lab? You can test by occlusions by balloon, like in case of ASD and PDA, and after the balloon occlusion, if you will see the fall on the PVR of at least 20%, then we can give a favor for closure and such shunts. Similarly, the important thing is that immediate reductions of PA pressures may not translate long-term benefit. This is also very important. And in the final, cardiovascular imaging is allowed. It allows accurate quantitative of the RV volume and mass. It also provides information on the other cardiac chambers. Reproducibility is excellent, and it allows for a standardized assessment of the RV function. Congenital abnormalities like aberrant pulmonary veins or intracardiac shunts can be we can find through the MRI. Several cardiovascular MRI parameters provide information on the prognosis and also the risk factors. Stroke volume and RV ejection fractions are strongly predictor of the prognosis, both at the baseline and during the follow-up. So finally, comprehensive clinical evaluation supplemented by echocardiography allow adequate hemodynamic assessment for decisions making in more than 95% of patients with left to right shunt. Cardiac cath and pulmonary vasodilator testing is often done for borderline situation, uncertain incremental value. It still is we can't, he's a puzzle for that. Can we do it or not? Or similarly, some exception, test occlusions of PDA and ASD by balloon give you support for result or support for the shunt closures. Thank you. Question?
Question at the end. Thank you very much.
Thank you.
Our next talk is by Professor Ijaz Hussain. He is Professor of Pediatric Cardiology at Peshawar Institute of Cardiology. He will talk on percutaneous VST closure in adolescents and adults, a case-based presentation. Thank you.
Assalamu alaikum. First of all, I am thankful to the organizing committee for giving me an opportunity for this talk. I'll just focus on mainly intervention in those patients who require VSD closure. So the guidelines for the closure of the VSTs in adult are very clear. So according to the European guidelines, the symptoms are not important. So any patient who has LV volume overload with a PVR of less than 3 that VST need to be closed, either surgical or device. And then in those patients, so that's the green. And those patients whose majority of the opinion is to close are those who had infective endocarditis, who had involvement of the aortic valve, and those border cases in which the PVR is between 3 to 5. So less than 3, and then 3 to 5 is we need to close them, majority of the consensus. And then may be closed is any PVR less than is more or equal to 5, but then the QPQS is still significant, then they may be closed. And then those who has more than 5 PVR presenting with desaturation on exercise. So desaturation on exercise is the first time that it was included in these guidelines, that we try to do the exercise testing of those who have desaturation during exercise, then is contraindicated to close. So I have just a few cases. A 13-year-old boy who had dyspnea on exertion, repeated chest infections, chest X-ray showed cardiomegaly, echo showed muscular outlet VSD and LV overload. So those with muscular VSDs and high muscular VSDs, we try to approach from various, so either from venous side or from arterial side. So this one, sorry. This is time taken to play. So this is arterial approach, retrograde approach from the arterial side. So we have, I'm not sure that's not playing. So anyway, there's a VSD, which we can see the device through that. So here it goes. So there's a left ventricle is dilated, and there's a LV gram with the pigtail catheter, and there is a muscular outlet VSD with a quite good distance from the aortic valve. So in this case, we used a muscular VSD device, which has both retention discs through arterial approach. So here's the device delivery. So the RV disc is relieved, device is pulled back, and then the LV disc is, and here we see the check whether it has closed the VSD in the right position or not. And then final is the release of the device, making sure the aortic valve is okay, the distance from the aortic valve is quite. So in this case, we used a muscular VSD device because we had a lot of safety of the aortic valve from the VSD. So muscular VSDs, we use muscular VSD devices. And the consensus is basically like in US, only muscular VSD device, there's a clear-cut indication to close the embodied device, and the post-surgical ones. So these two are, there is no controversy. The rest, there is debate. Some people, they do close it, some people, they don't. So muscular VSD and post-surgical VSD, there is no controversy about device closure. So this was a 17-year-old boy who had the same features of heart failure with cardiomegaly on X-ray. This patient has actually a moderate to large posterior muscular VSD. So posterior muscular VSDs are really difficult to approach from either arterial side or from the venous femoral side. And moreover, this was near the tricuspid valve as well. So what we did, we planned for closure from the neck. So they are easily approachable. So the apical one and the posterior muscular ones, they are easily approachable from the neck. So in this, we can see, this is a catheter from the neck, multipurpose catheter into the pulmonary artery, which is ready to snare the wire. This is a large VSD, which we can see with a significant LV overload. And this is, we all know, snaring, crossing the wire through the VSD into the pulmonary artery, and then snaring it to the neck to make an arteriovenous loop. And in this particular case, we used a PTA device. The reason was because this patient had the tricuspid septal leaflet was very near the RV side of that. So we avoided the RV disc, which can entangle the septal leaflet. And here we can see that the VSD is almost closed with a little bit foaming of that. So various devices according to the location of VSD and the involvement of the valves we can use. There's another female who had the features of heart failure with a moderate PM outlet VSD with LV overload. So in this, we use the femoral venous approach. So for outlet VSDs, if we go for the closure, so we go through the femoral vein. And this is the patient, like sometime, why there is a controversy of closing the VSD with device or not, is because of the risk of heart block. So the heart block is basically is not on the table like the surgical one. So it happens after some time. So that's why, like this particular patient, she went home and then had a syncope, and we had to readmit, put a TPM, and then give steroids, and luckily she recovered. So this is the main concern, that whether to close or not the VSD, the perimembranous VSD with device. So it's the LV-gram with a significant large VSD, and here we can see from the femoral vein we pass a sheath into the ascending aorta, and then there's a device which is across the VSD, and it's released. Although it looks a bit oversized, but still there is some shunt over there. So heart block is one of the complications which we may see in such patients. So there are various devices, softer devices, which have been introduced, in which the risk is lesser. And this was an 18-year-old girl who had moderate PM outlet VSD, was near the outlet, and we were worried about the aortic valve. So generally, if there is potential risk of AR or impingement of the device on the aortic valve, better to use the venous approach so that you stay away from you really know the situation of the aortic valve before release. So this is LV-gram, in which see a perimembranous VSD. Here is a device which is called MFO device. There are very soft devices. Here we can see that the device is quite away from the aortic valve, but still before release we need to be sure. Because if we close it from this side, then the sheath would be through the aortic valve, and we will not be sure whether this AR is because of the sheath or because of the device. So usually, if you are worried about tricuspid valve, try to be, if using MFO device, we need to be away from, use the arterial approach. If you're worried about the aortic valve, then better to use the femoral vein or neck vein approach. And here are the final release, and then the So this is another case who, 82 years old lady with anterior wall MI. She had breathing difficulty on support with bilateral grafts. And the coronary angio done, which showed triple vessel disease, advised CABG, but a surgical risk was high to refer for intervention. So in this, so here we try to avoid general anesthesia because they are really, if the patient can tolerate, we counsel them, they can, and they can lie down as well. So usually we do under transthoracic guidance, and if like it is very apical and the approach is difficult from the femoral vein, usually we prefer to have neck approach. And here we can see it was a long tract, so that's why we used a 20 mm ASD device in that particular case from the neck. The neck approach is usually because there is not a loop. When we go from the femoral, you have two loops. So usually the VSD and the ventricular septum is like stented. There's a force on, and you have a lot of runs of VTs and all these, and the device may slip through. So generally, neck is the safest approach to go for post-infarct VSDs, because you have very stable position of the sheath and device both. Usually we avoid contrast a lot. The reason because they've already compromised renal functions. We usually see on echo if there is not much issues, we usually don't. So we had, in this particular case, we had just one angiogram. Sometimes even we don't give a pigtail proper angiogram, but just a hand injection to see where is the location and how to cross it. So they are really sick patients. They need sometime we use intra-aortic balloon pump. These are the cases in which we really need adult cardiologists. So like in adult congenital, I think this is a two-way game. We need them a lot. I never do coronary angio. Even in my ASD patients, I ask my colleagues to please come and do coronary angio for me. So I have never done a single coronary angio in my life. So because it's not my field. So the same is that in these particular cases, we just close the hole, but the rest, management of hyperlipidemia, management of hypertension, diabetes, I don't know. So intra-aortic balloon pump, so the adult colleagues help us. So really, post-infarct to develop, we need adult cardiologists. We need referral from them because adult cardiology is their patient. So like in this particular case, we are really helped in our institute by the adult cardiology team. So this is the area which we like. Sometime we really like for all, like intra-aortic balloon pump, we don't use in pediatrics, so they use very frequently. And it's very important because for stabilization, this very low margin, because once their creatinine is high and the functions are low, so then it's very difficult to control them. Okay, Jazakallah.
Thank you very much. Sir, our last talk is from Dr. Abdul Sattar. He is Assistant Professor of Pediatric Cardiology at NICBD. He will talk on addressing the secondum AST in elderly, a case-based presentation. Thank you.
Assalamu alaikum, everyone. So already we are running short of time. So my topic is the adult congenital heart disease ASD colloia, mostly secondum. Here we can see the population of pediatric versus adult congenital heart disease is changing with time, especially in the developed countries. Already most of the patients are treated or operated and living their adulthood or adolescent. And their outcome is a very much better as compared to developing countries. The main reason why how they can achieve this, by early diagnosis, timely referral, and appropriate management. Their survival improves from 20 to 90%. But still in Pakistan, we are facing a lot of the problem, like late diagnosis, late referral, and alternative method of treatment. That's why most patients are presenting in the adulthood or adolescent with the multiple complications. And most of them is the ASD. Because ASD during early age remain asymptomatic or with mild symptoms, and many times unable to pick by general physician and pediatrician. In ASD, secondum ASD is most common, and its natural history is that if it's a shunt is small or not significant, mostly remain asymptomatic during early age, and they are developing the pulmonary hypertension and other complications of mostly third or fourth decade. And many of them pick during visit to doctors for other issues, like the preoperative assessment or other chest complaint issues, or during pre-medical assessment, or for any medical assessment for any job description. So other patients who are presenting with sign symptoms, and these patients who are present with sign symptoms are the ASD with a complication related to left-right shunt or other associated comorbids. Like they are developing the ventricular dysfunction, left and right ventricular dysfunction, and or they are developing the arrhythmias, mostly the atrial fibrillation flutters, are developing the pulmonary hypertension, paradoxical emboli, CVA, or during pregnancy due to volume overload, or due to secondary infection or COPD related issues. Otherwise, it's a indication for the colloia is very simple, that if any patient who is with a significant left-right shunt and show the volume related dilatation of RV, and its PVR is less than 5 units, it must be treated for the surgical or device closure where is the feasible. But device closure for adult is a treatment of choice if it's a deviceable. It's a class 1. Class 2A is if a patient with a ASD, with or without symptoms, with or without ventricular dilatation, if there is any paradoxical emboli, it's a class 2 indication for the closure. And class 2B is if its PVR is greater than 5 unit, but its ratio is less than 2/3 of the systemic vesicular resistance, or PA pressure less than 2/3 of systemic pressure at baseline or after vasodilatation. But with the net left right shunt and a QPQS of more than 1.5:1, so 2B. And 3 is the ASD with Eisenmenger is a contraindication for the closure. Here I will present a few cases like we had the one patient of 50 years old male patient referred by the pulmonologist for the cardiac evaluation. He was visiting since 1 year to these physicians and pulmonologists for the shortness of breath that is worsening with exertion, sleep disturbances, orthopnea, and palpitation. Multiple treatment options given and courses completed, infection also treated, but there was no improvement and condition was worsening with the time. He is a smoker, hypertensive, asthmatic, and diabetic. So when he was referred, he was in functional class 3. His JVP was raised, peristaltic heave, epigastric pulsation, and loud P2. His X-ray, here you can see clearly the dilated pulmonary arteries with a distal pruning, and also later X-ray you can see hugely dilated pulmonary arteries. So ECG also shows the right axis deviation, right ventricular hypertrophy, and signs of the pulmonary hypertension, RV hypertension. But sinus rhythm and no coronary, no ST changes. Here you can see echocardiography, dilatation of the right atrium, right ventricle with a right ventricular dysfunction and a severe regurgitation. That is PA pressure is around 100. And mostly left right shunt, but there's a minimum bidirectional shunting also on echocardiography. So his echo showed the depressed functions, and LV is also preserved, and IVC dilated, non-collapsing. Baseline saturation was 92% at room air. 6-minute walk test showed the only 230 steps with desaturation up to 85%. That showed significant bidirectional shunting. So his cardiac cath done, that showed the QPQS, baseline QPQS 0.9:1 with a high PVRI, 11 Wood unit, and post-hyperoxia, there was also no significant improvement. Still the QPQS 1.5:1 and PVRI 7, and PVR-SVR ratio 0.4:1. So his EDP was also normal, peer pressure systemic, and no coronary involvement. So this patient, CT scan done by the pulmonologist to see any lung involvement. Lungs was okay, but hugely dilated main and pulmonary arteries, and there are no thrombus. So he was started with anti-filial, antihypertensive medication. His hemoglobin optimized, and pulmonary vasodilator also started along with respiratory and support care. So after stabilization, he was discharged to home after 1 week with the advised regular follow-up and with rehabilitation and pulmonologist visit. So his 3 months visit, he advised to visit every month. After 3 months, his echo shows some improvement with a reduction in the pulmonary hypertension. Baseline saturation improved from 92 to 95%, and functional class also improved to in class 2. His 6-minute walk test also improved, but still there was desaturation. So he was continue with his supportive medication, and cath also done. That shows some improvement, but still baseline PVR is a 9, and after vasodilatation it's a 6, and QPKS is a 1.5:1. And with PA pressure little decrease, but still EDP is high. So again, same supportive medication along with the vasodilators continues. After 6 months, there was some significant improvement with the function. RV function improved to normal, and his PA pressure dropped to less than 2/3, and LV function also improved. Saturation baseline 97%, and there's a no desaturation on the 6-minute walk test. He achieved to reach the 480 steps and functional class 2. His echocardiography also shows there's a significant improvement in function and reduction in pulmonary PA pressure. His baseline cath showed the QPQS of 1.3:1, PVR 7, and ratio of 0.38:1. Hyperoxia shows some improvement, the QPK 1.6:1 and a PVR 5, but PVR-SVR ratio 0.25:1. His PA pressure also dropped and ADP also improves. So at that time, we decided to do the balloon occlusion. After balloon occlusion, there was some increase in EDPs, but it still remained less than 15. LV, RV, EDP remained less than 15. His PA pressure dropped from 85 to 80, but aortic pressure remained stable. So we decided to do the balloon-assisted fenestrated ST device closure. So a balloon occlusion test is clearly defined that if in first group, if LVEDP greater than 15 but less than 20, with a pulmonary capillary wedge pressure less than 20 and a systemic arterial pressure remains same, you can close the ASD with fenestration. In group 2, if LVEDP is greater than 20 with a capillary wedge pressure greater than 20 and a systemic pressure drop more than 20%, do not close the ASD. In third group, if EDP is less than 15 and a systemic pressure remains same and or increase and capillary wedge pressure less than 20, you can close the ASD without fenestration. So our case was the systemic pressure was okay and no EDP significant changes. In that case, you can see device was stable and but there was no dysfunction, no increment in the EDPs, and the patient remained stable. 3D also showed the stable device without any complication. So this patient remained on the close follow-up. He was improving with a working condition and other things. There were no desaturation. So he was in close follow-up up to 1 year. After 1 year, he lost to follow-up. Then suddenly, he visited in emergency after 2 years of follow-up. So at that time, he was very sick with a shortness of breath, functional class 3, with pediatric edema, raised JVP, ascites, because he discontinued the medication since 1 year and was not taking any follow-up to any physicians. At that time, again, here we can see the dilated RV with a dysfunction and a septal bouncing, means the RV pressure is almost systemic. At that time, we did the echo that showed the severe RV dysfunction, dilated non-collapsing IVC, and severe pulmonary hypertension. So he is admitted in ICU with inotropic support, anti-failure, pulmonary vasodilated diuresis, and condition stabilized, but he was in the borderline condition. Family and a patient was counseled closely. So in this patient, our message is that this patient after device closure or after surgery, it's mandatory to counsel the patient and family for the close follow-up. Because if they are not following and not taking medication, patient can rebound with the pulmonary hypertension, RV dysfunction, or arrhythmias, and condition can be worse like this. So second case is 61 years old lady presented in ER with severe chest pain since 1 hour. Had the shortness of breath on exertion and chest discomfort since few months. That was progressively worsening. She had the comorbids like diabetic mellitus, hypertension, family history of coronary artery disease, and also has the past history of chest infection. She was tachycardic with hypertension. So at that time,
Dr. just 2 minutes.
Okay. So emergency decided this patient is most likely the case of the coronary artery disease, because ECG shows the ST changes and drop I was positive. So patient was shifted to cath for the primary PCI. So in case you can see this is a discrete severe left LAD, mid-LAD occlusion. So it was stented, mid-LAD was stented, because at that time echo was not done. So after stenting, patient shifted to ward, and later on echo done, that showed the large ASD with a mostly left-right shunt and dilated right ventricle, right atrium. His case also done at that time. That showed the QPQS baseline 1.4:1 in PVR 7. At that time, it was decided this patient had the coronary artery disease, gave some time for the stabilization and recovery. So after 3 months, this patient, at that time, balloon occlusion was done. That showed the EDP increase from 12 to 17, and PA pressure was systemic. That's why the patient was decided to follow. Later on, after 3 months, patient again gets done, they show the significant improvement in function and EDPs, and also the AC device closure done. Patient was stable and discharged to home.
Yes, conclude this.
Okay, so it's a third case, also same type. This patient also presented with in emergency with exertional dyspnea, had the hypertension, diabetes mellitus, functional class 3, and also signs symptoms of RV failure, palpable liver. This patient also, X-ray showed this, also EC showed the significant ST changes. So adult cardiology team shifted this patient. Echo at that time done, they showed the dilated right ventricle, hypertension, hypertensive RV, and a large ASD. So his case here showed the pulmonary hypertension and QPQS baseline 1.5:1. So left main shows there's a diffuse circ obstruction and a left main and a LAD obstruction. So at that time, left main to LAD stenting done, but RC circ was diffusely disease, that was left. Circ was left and not treated. So this patient was optimized and discharged to home, and ASD device planned to after a few months. So after 3 months, patient visited with a good state and had the 6-minute walk test for 30 minutes and no desaturation. Heart failure was also improved. At that time, ASD device closure done and without any complication. So this patient, after few days, developed the heart block. Initially, it was transient, then become complete, and on and off it was transient to complete. So steroid was started, and patient reverted to sinus rhythm, but still had the intermittent transiently heart blocks. So we are following, and it's up to cardiologists and electrophysiologists. They are thinking this is a diffuse disease, so we have to follow conservatively. But patients asymptomatic with a good rate and hemodynamically also stable, no complication. This is a fourth case, 57 years old, came for the preoperative assessment of for the prostate surgery and incidental finding of the ASD. So patient was asymptomatic, there was a large ASD. So device was done without any complication. So this patient, after device closure, developed the persistent atrial tachycardia. Even after antiarrhythmic drugs for 2 months, tachycardia remained persistent. So this patient, we did the electrophysiological ablation, and we punctured the septum above the device and did the EP ablation successfully. So there's already literature present. There's a 6% incidence of arrhythmias and blocks in case of SD, more common in the device closure as compared to surgery. So key point is that diagnostic catheterization also indicated in the adult and elderly patient for the pulmonary hypertension and coronary artery disease, ASD with a pH. If PVR more than 15, check the vasoreactivity. Fenestrated ASD is a better option. And vasodilator also needs the for the long term, and don't stop after closure. Slowly monitor and taper slowly, and there may be a chance of rebound hypertension. And also arrhythmia and AV block is also common in these patients. Follow for the arrhythmias. Baleno-occlusion test for the elderly patient is also important. It will provide the additional benefits. Also, fenestrated ASD device in these patients will prevent the rebound hypertension in the late stage. Also, balloon-assisted device closure is also helpful because their septum and rims are floppy. So assisted device is good for these patients. And long-term follow-up is mandatory for these patients because they will develop the arrhythmia, dysfunction, hypertension, and other complications in late stage. Thank you.
Thank you, Dr. Sattar, for a comprehensive talk. I think we would close this session because we are already delayed. We have one more case which is live in box by Professor Asifur Rahman. So I would request Professor Amna to take over the stage and thank all the chairpersons for this meeting. Thank you.
Assalamu alaikum. Thank you very much for a very lovely session. The next session is going to be live in box. And I would like to invite the panelists for this discussion to come on the stage. Brigadier Khurram. Brigadier Khurram, if you would like to take a seat on the stage, please. Professor Syed Najam Haider, Colonel Mehboob, Dr. Abdul Razak, and Dr. Abdul Sattar. Thank you very much. Now I would like to invite Professor Dr. Asif Rahman from Punjab Institute of Cardiology to give his presentation on the device closure of a very large PDA with severe pulmonary hypertension. Thank you.
Bismillahirrahmanirrahim. Assalamu alaikum, everybody, respected teachers, and thanks to the organizers and chair to give me the opportunity to be here with you people. And it's showing on a very interesting case. I was not expecting this case to be very interesting at the end, but ultimately we did it, and I am happy to show you with my experience and thoughts and afterthoughts about this case. Can we have... video. Assalamu alaikum. I am Dr. Asif from Cath Lab 4 from Punjab Institute of Cardiology. With me is Dr. Hussain. He is Associate Professor at Children's Hospital to complete this case, and Cath is being done by, a machine is operated by Javed, and with me, Dr. Afzal will join us hour late, and Dr. Sister Sadi is here to keep the supply line intact. So briefly, I will tell you about this case. He is a 16-year-old boy, and he presented in outpatient with palpitation, easy fatigability, and he has never been visiting any cardiology facility before that. He presented with failure to thrive, repeated chest infections, and he has been treated off and on with like a hyperactive airway disease. And now he presented first time in our outpatient department where he was examined, and he weighs 35 kg, so he has grossly failure to thrive. He has high volume bounding pulses with a wide pulse pressure, and he has clinically significant cardiomegaly, and apex beat is heaving, and it's outside the mid-clavicular line, and it's the 6 intercostal spade. And there is a rough systolic murmur at the left upper sternal border, although at that bit spills into the diastole. His chest is clear, and rest of systemic examination is unremarkable. This is his 12-lead ECG, and you can see in lead 5, V5 and V6, large R waves and Q wave that shows dilatation of the left ventricle. This is our X-ray chest that shows increased prominent pulmonary vascularity and significant cardiomegaly. This is an M mode of this patient, and that shows a very dilated left ventricle, which is 6.6 centimeter, although the function is preserved. And this is parasternal short axis that shows a very smooth non-laminar flow during systole, and there is a light mild turbulence during systole. And there is a large PDA that will show you in a 2D clip. And there is a wave Doppler which is only shows a velocity of about 3 meters per second. And there is no flow in diastole. This shows a PDA which measures about 2 centimeter on transthoracic echocardiogram. So our plan is to assess the hemodynamic of this patient, and if we will consider possible, we will do an occlusion test, balloon occlusion test of the duct to see the pressures and saturations. And then we will, if it comes suitable, then we will percutaneously occlude this by a device. So the device that we thought that we will use a PI muscular VSD device, being a large duct, and to be safe because this has got 2 discs on the both sides. Although the PDA devices are not available in such a big size, and usually they all are single-sided discs, so they are a bit unstable. So what we have done so far. कर सकते हैं
आपकी आवाज़ नहीं आ रही कल मैम, आप बेशक ऊंचा बोल लें. आई थिंक दैट विल बी बेटर इवन.
सर 20 अगर वाकई मेजर हो रहा है तो 22 तो प्रॉब्ली इट्स टू स्मॉल. और सिर्फ एक सर आसिफ मेरा सवाल था कि सैट्स का डाटा है हमारे पास अपर लिम्ब में, लोअर लिम्ब में?
I will show you the QP-QS ratio. I will show you because I presently don't have exact saturations in different segments of the heart.
But I think if there was a left to right shunt, clearly, probably the saturations in upper and lower limbs were the same. And he had shown a clear systolic gradient, which was 3 meters per second. So I think probably the saturations were normal in upper and lower limbs.
The reason why we selected a 22, it was not by selection, it was by compulsion. We don't have a VSD device bigger than that. Upper size which is available by the company is 24. We don't have in our shelf. So we have a lot of problem with a couple of years for the supply line. One thing. Second thing, if the waist is 22, the disc is 32. Right? So I thought that it would hold on the aortic at the pulmonary end, and we might have some residual defect, but it will close definitely the duct. But let's see. Can we play the video? So catheter is in the pulmonary artery and other is in the pigtail. So we got saturations and we calculated the QP-QS and pressures from the aorta and pulmonary artery. We did an angiogram. It's a large duct. Although it's not clearly visible on that side, we did a right angiogram, RAO, and that shows a large PDA. We measured it about 16 on angiogram. So this is the aortic pressure, which is upper side that goes 120 by 80 over 93 in air. So we will switch over to PA pressures, and mind it, this is without occlusion of the duct. So the PA pressure is 94 by, so QP-QS in air is 4 and aortic pressure is 120 by 80 and PA pressure is 95 by 64 with a mean of 74. There is systolic pressure about 20 and mean pressure of 20% difference. So even then we tried to occlude the duct with a 22 mm balloon, and we anchored it in the duct. We are going to upsize the femoral vein sheath with the 035 implants or wire across the duct. So here we take our 22 mm balloon across the duct, and we'll inflate it, and let's see what the pressure comes. So this is our PA pressure while we are inflating the balloon. So really bit difficult to stabilize across the duct. We inflated, and you can see there is hardly any waste over there. And we will see what the PA pressure comes in. So it's almost same, and let's see whether we have occluded the duct completely or still there is a residual flow. So aortic pressure is same, and it didn't change. That we were expecting that it will rise after the occlusion or after occlusion the shunt from the duct. So we try to do an angiogram. So while manipulating the pigtail, it just flicked into the pulmonary artery. So I thought there is still a large residual shunt there. But anyway, so did an angiogram in for lateral, almost same amount of contrast as in the aorta, it's in the pulmonary artery. So there is a significant residual shunt, both on the RAO and the lateral projection. So what to do now? Should we put the same device, send to the surgeon?
I think there are a couple of things here. One is that you are using a 22 balloon, so that's clear that the PDA is actually more than 22 millimeters, although you measured it 20 on echocardiogram. And second, I think I would not have used a 22 device now after this, but I think you probably did.
Oh.
Also, the QPQS that you have mentioned is 4. And if it depends on the sampling, if you have taken the sample from the pulmonary artery, the PDA
so we moved on. I took a cook sheet. Obviously, it's a multi-purpose sheet, and we don't have a PDA delivery system of that much size, which is 12 French. And we all know that it's not meant to be land in the aorta through the pulmonary artery due to the acute angle. We try to manipulate it to make a curve bit more so that it can accommodate it, not going to irritate or disturb the aorta. It's a 12 French, and so we're going through the RBOT, pulmonary artery, through the duct into the descending aorta. And I told earlier that considering just the safety factor that we have got 32 discs, so it will definitely hold in the aorta and in the pulmonary artery, although we are expecting that it might have a residual duct. Unfortunately, we can have a custom-made PDA device for such a large duct, but obviously due to current situation, we cannot get that. So we tried that. PMI. This has got 2 discs, screw on the RV disc, and there is a welded hub on the left side. So the loading is similar as to any other device. We pass the delivery cable through the loader, and now we will screw it up. So we're going to check the stability of the device, which is manifested by a click, and we can also push it so that's properly screwed up, and then we suck in into the loader. And now we're taking it, and we can see something interesting will happen. So simultaneously we are recording the PA pressure. So we'll release the LV disc in the descending aorta. Bring it back into the ampulla. Release a bit more. Oh. So by the time the device takes its memory, it slips back into pulmonary artery. So what are the possible, why the device lost its memory?
Some cobra formation.
Yes, but why? Usually VSD device doesn't lose that. So probably I thought I use a wrong delivery, although the delivery cable was compatible with the screw, but it was very thin and it's not going to transmit my force that can break up this deformity of the device. So I changed the cable now, and I got a bit more stiff cable, which is for ASDs. So same device with a different delivery cable. So it's got the PDA captured, but still the LV disc is a bit more cupped in. So we did an angiogram, still shows significant residual leak, and RAO shows a relatively good position of the device. So I waited a couple of minutes, and after 2-3 minutes, when I did again fluoro, the device is in the pulmonary artery. So I thought we should give another try. So recaptured the device, take it into the aorta, and I thought I should release a bit more in the aorta rather than in the ampulla. So now I release all the device in the aorta. So I recaptured, readjusted, and redeployed it. This time it looks a bit better, but still you can see the LV disc is smaller as compared to RV disc. So it's still being squeezed. So it readjusted itself, but after a couple of beats it slipped on. So what next? Sorry? So now we should use, either we should send it to the surgeon or use another device. So no VSD device bigger than this is available. So only
let's ask Asif people what would they do here. Satar, what would you do?
I think device looks, PDA looks deviceable, but a size of a device is not appropriate.
So what device would you use now?
So whether if you are taking the PDA, at least for this patient looks like a 26 plus. Second thing is you can take the ASD device.
Khurram, what would you use?
I would go for an ASD. I would have gone for an ASD device in the first place.
First instance. Yeah. Najam, what would you do? Same.
I think so we have to use the ASD because size was quite big, 20.
Okay. Anybody else who wants to contribute?
Can you go back and show the first injection to see the anatomy?
No, we can't go back.
Okay.
It's a recording.
Okay.
So, the only option for intervention is now an ASD device. So with the 22 muscular VSD device, will you use a 24 ASD device? I thought not. I should go for 26 or 28. Both were not available in the shelf, so only option was left was a 30 mm. So the LA disc is 44. It's a very big disc. To accommodate a 16 years old, 35 kg baby, and how it would hold, but that was the only option. So I started with a 30 mm ASD device.
It's an expired device though.
No, there's a box picture, that's not the device. So principle is same, and we secure it on the delivery cable.
Actually, 22 devices really sharp. Maybe it's not going to come. It is.
So releasing the LA disc in the aorta, making it more flatter, bring it back. And at this stage, it looks that this has filled all aorta almost completely. So releasing the RA disc operated a good position, but LA disc has almost completely occluded the aorta. So we got the pigtail in and tried to take the pressure gradient from ascending to descending aorta, and there was a systolic gradient of about 15 to 17 millimeter of mercury. So how to manipulate this device? We thought to use
balloon dilatation.
A balloon which is 24 Tyshak balloon, and that takes a sheath of 8 millimeters. So we are going to change it because we are going into femoral arteries so as to decrease or minimize the injury to the femoral artery. So this is 24 mm into 4 centimeter tie-check balloon. So we are there, and now we'll inflate it fully so as to compress it against the aorta, and we see whether we are able to abolish the gradient across the upper half or in the aorta due to this device. So we inflated it, and you can see a beautiful cup has been formed, and it has circumferentially covered the duct. So we did an angiogram both in lateral and RAO. We got the pressure from ascending to descending aorta, and there was no gradient. This is a PA pressure before we release the device, and the PA systolic pressure has fallen, both diastolic and mean pressure has dropped down very significantly. And if we will show you the aortic pressure, that has increased simultaneously. So we opted a very good result. There was no residual shunt, and there is no gradient across the aorta, and pressure has fallen significantly, and I think we have achieved what we was aimed for. Although we used an off-shelf septal occluder, which is very rarely used in occluding the PDA. So this is the final angiogram after we release it.
Any LP stenosis?
No, the second day we did an echo on this patient, and there was no residual gradient.
So इसमें echo की findings है post device closure?
Post device closure, there was LV dysfunction, but otherwise there was no gradient. There was mild residual leak still there.
Hemoglobin drop, hematuria?
No hemolysis. Restenosis of actually what happens when you close a very large duct, there is remodeling, because at the moment PDA pulmonary arteries are dilated. So after a couple of months, that will there will be remodeling. So there is always possibility of stenosis, but in aorta definitely it will not, because we have stented so many patients. Their stent also protrude into the aortic arch, and if it is now there is no gradient, it's not going to produce gradient, because it's only 16. Still 2-3 years are left to attain her growth potential.
16 growth potential.
Balloon size आपने कैसे select किया?
It was just not observation. This is a hard thinking. We can use up 24 because we have the largest balloon is 24 or 25. We don't have a bigger balloon.
Without measuring the size of error, so how?
Actually, what I tell you, I got a CT of this patient, so I know where the measurement is. So the maximum diameter that CT shows us of duct was 23, and it was almost 27 millimeter aorta. So 24 was enough to compress the septal occluder against the aortic wall.
The balloon was used it was used to remodel, push the aortic disc. It was not used for any other purpose, not for dilatation or anything. You just need to push the disc. The very important point here is you should not release the device when you're doing such maneuvers. Otherwise you should not release the device. The device was still cabled. Okay, you should not release it, and otherwise you can embolize.
If there is such a large duct, you can wait 5 minutes, 10 minutes before you release the device.
I think there is another learning point here is if you look at the data when you occluded it with a balloon, there was hardly any drop in your PA pressures. And that data would have misled you otherwise as if whether this is doable or not. Once you closed it completely with a device, your pulmonary artery pressure dropped significantly. And I think that reflects Mazni Alvi's paper, if you remember that, which he wrote many years ago, where they would not use a balloon as a test occlusion. They would actually put a device there and then not release it and see what happens to the pulmonary artery pressure. Of course, it has cost implications because you could potentially waste a device if it's not dropping. But I think there's a very good learning point here that if you close it completely, you might get a totally different hemodynamic outcome vis-a-vis a balloon which is difficult to stabilize. You may not get an appropriate drop in pulmonary artery pressure, and you can make a wrong decision there as well.
Actually, another practical point is if the bigger balloon, if you will use a bigger balloon to occlude the duct, it will occlude the aorta simultaneously. So aortic pressure will not make it easy to make the balloon stable across the duct. It will keep on popping due to the pressure gradient.
Any comments from the chairs before we close it? Because there's a closing session in Hall A and they had requested all of us to join them over there. So if there are any closing comments from chairs, otherwise I think we can
you
close.
made a very important point about the device closure versus test occlusion of the duct with the balloon. There was a paper published few years ago from our neighboring country. What they did was, like in the PDA with the pulmonary hypertension group, they closed the PDA with the device. We didn't unscrew it, just leave it for 24 hours with a screw and cable in, and then release it after 24, which is like a very valid point, I think.
That's what I was referring to. Mazni did that 20 years ago. That paper was published 20 years ago from Malaysia. Yeah.
I think it was very well managed and very well managed case. Excellent, sir.
And thank you, my team, and thank you, Professor Masood Sadiq Sahab. He has always been inspiration and giving advice of what to do next, and thank you very much.
Thank you very much.
I think we can move to the next hall because there is a closing session there.
Yes.
And